They just actually bestowed upon him in 2017 their highest honor, the Alumni Citation for his research work in medicine. He attended Rush Medical College in Chicago and followed by the Mayo Clinic for anesthesiology training, where there he specialized in cardiothoracic anesthesiology and was a chief resident. He returned to Rush for his first faculty position from 1983 to 1990. From there, he traveled on to Seattle, Washington, and there he left Washington State when a business opportunity for his new wife presented itself in Richmond, Virginia. He took the position of vice chairman in anesthesiology at Virginia Commonwealth University in Richmond, Virginia, where he stayed there for 17 years until pursuing his last position at the University of Florida. Dr. Spies has focused his research upon blood, its critical oxygen carrying capacity, oxygen therapeutic pharmaceutical development, previously known to us as blood substitutes, the risk for transfusion, and coagulation, coagulopathies, and the development of monitoring technologies. His extensive work in blood transfusion risk has led him to be an outspoken proponent of patient blood management. He's authored over 200 peer-reviewed academic articles, more than 40 book chapters, 7 textbooks, and has even appeared on the Discovery Channel and many other lay media. His work has been funded mostly by the United States Department of Defense and has led major conferences for the Department of Defense, the National Institute of Health, the FDA, with regard to critical blood issues. As it pertains to patient blood management, Dr. Spies has spoken at SABM a number of times and on every continent, with the exception of Antarctica, where currently blood management is not a great issue. But he has worked with governmental agencies, particularly in Australia, to enhance the support for liberal thinking on blood management. His present work at the University of Florida has a major focus on trying to get that very large medical center to become a showplace for anemia correction, as well as to become a world center for bloodless medicine. Dr. Spies is particularly proud of his involvement with the Special Forces, the United States military, and its efforts to help government agencies understand the issues of when blood is not an option. Dr. Spies has won several awards, including the Award of Excellence of the Bloodless Medicine and Surgery Society in 2019 for his excellent contributions to the science and the practice of bloodless medicine and surgery. So what more can we say? With further ado, Dr. Bruce Spies.
Thank you so much, Sharon. Let's see if are my slides sharing.
No, not yet.
Okay, let me share these slides and see if we can get it to work on the. There we go. Good morning, everybody. It's so wonderful to see so many people that I know from around the world, and it's very heartwarming to share a common cause with so many of you. It is a common cause. It's a bit of pushing rocks uphill, and I've been doing that for 45 years. And last year, Nathaniel was good enough to ask me, maybe Sharon, a bunch of you were involved with asking me to give the keynote address, and I'm really touched that you came back and asked for me to do a similar talk this year. I think last year, my feedback was that I was a bit outspoken. And Nathaniel has challenged me to consider giving a talk at SABM about the similar kind of discussion. And so over the last year, I've had a great deal of time to think about it and expand in my mind on what I said last year. So if this year's talk is even more outspoken, I'm not going to apologize for that. The point is that bloodless medicine is a superior form of healthcare, and we need to tumble to that as our ultimate goal. So without further ado, let me get going on it. I have a number of disclosures Perhaps my number one disclosure that I'd like to put forward right now is a bit of an advertisement for you all, that there's a new book that has just come out called Blood Works. And I'm so proud to have contributed to that book. It is perhaps one of the finest books I've ever read on the subject, and I put it forward to so many people that I work with that they really simply need to read it. You can see that I have been involved with a number of companies over the years. None of those I think are going to come into play today. This is where I left off last year as my conclusion, that blood is a complex organ and that we don't really study it, and medicine doesn't really treat it as an organ, and we don't teach it as an organ, and we don't do research on it as an organ with its complexity and its interaction with the vascular system. And Nathaniel and others have already spoken to the point that when we do a transfusion, it's a transplantation. It's an organ transplantation, and we don't do organ transplantations on anybody else until that organ has failed, and that failure of that organ is otherwise going to lead to the patient's death. We give blood transfusions for any number of reasons, and so you have to ask the basic question of do we really know what we're doing? So I think bloodless medicine has or should, it hasn't yet, but it should become the default position for all of us. And patient blood management is an evolutionary step on that towards the idea that bloodless medicine is where we ought to go. This is also from last year. Ecosystems can be beautiful. The complexity of the ecosystems is what I love. And what I love about biology, and I was forced to learn biology by my parents. So it's really is in my bloodstream or in my heart or in my head. That the complexity, and every day, every week, every month, I'm finding some new piece of complexity. Right now, I tend to be diving deep into HIF1 alpha. HIF1 alpha is a protein that in every one of our cells tells every one of our cells whether it has enough of its own oxygen. And so how does that protein work? What's the relationship between that protein and all the other proteins in the body that are regulating oxygen? Fascinating, just absolutely things that 20 years ago weren't thought of. So blood and the vascular system on our organ, perhaps the biggest organ in the body. It touches everything, and they're mature and they're balanced ecosystems. And when balanced ecosystems are balanced, they work beautifully. When they become unbalanced, things begin to fall apart. And then you have diseases. And we often, as physicians and medical healthcare professionals, think that by doing one intervention, we can put the entire ecosystem back together. That doesn't make any sense at all, does it? So once the ecosystem is dramatically disturbed, it's hard to restore that homeostasis that is what has evolved over millions and millions of years. So to understand an ecosystem, we must look at both micro events plus macro interactions. And I'll put it to you, when you and I give a transfusion, that's a macro interaction. That's an insult to the entire ecosystem. It's not restoring the ecosystem. It's an insult. Let's try to put out a forest fire by lighting a backfire. Well, once in a while that works, but sometimes it gets out of control and makes things worse. We can't oversimplify, and that's what we've done for years and years and years in medicine. And as I said, blood is a liquid organ. It's complex. I'm not going to go into it in so many different ways, but most often physicians focus on just the oxygen transport qualities of blood. And I'll put it to you today that I spent over 40 years of my career trying to understand that. I still don't understand it. And I think the average physician anywhere in the world has a very poor, very limited, and perhaps myopic concept of what oxygen transport really is, how it works, and especially in disease. So red cells are incredibly complex. They've evolved in mammals to regulate tissue oxygen levels. Regulate, not the more you give, the more oxygen you get. They are there to regulate. Oxygen is a toxin. Every one of us will die from oxygen toxicity. Chronic oxygen toxicity is what leads to superoxide radical generation, aging, atherosclerosis, inflammation, COVID, go on and on and on. How do our white cells kill things? By superoxide radicals. It's all fascinatingly interactive. So the normal levels of hemoglobin and hematocrit exceed critical needs by at least 5-fold. That's a take-home point I want everybody to have. How much red cells you have exceeds your critical point by 5-fold. And I'll talk later about how many times you have to hemodilute an experimental animal before you get to that critical level. You don't just hemodilute 5 times. It's a whole lot more than that. So normal hemoglobin and hematocrit levels have evolved, I believe, for regulation of vascular tone, shear stress, nitric oxide flux, signaling, endothelial cells, everything else other than just oxygen delivery. So RBCs are also important to coagulation. I'm not going to go through all the rest of this, but you can begin to see how complex it is. So my new thinking, I've given considerable thought to the subject. I like to hike. I live out in big mountains out in the western part of the United States. So when I seek solace in my life, I get out on the trail and I go up the mountain. I see all kinds of wild animals, occasionally a rattlesnake, something that might scare you, a few tarantulas, all exciting. But during the time that I'm out there, oftentimes I think about the big pressing issues in my mind. And this is a big pressing issue in my mind. How do we change the world's thinking on blood utilization? Unfortunately, in the last year, little has changed internationally, at least in terms of how the world is viewing blood transfusion and teaching and functioning the same way. Allogeneic transfusion is a human behavior. It is not science. It is a human behavior. Every time somebody orders a unit of blood to be hung by themselves or another healthcare worker, they have taken on a human behavior that's a complex end action of belief systems that they have. And that's what it is. It's an end action in response to belief systems. And transfusion has been filled with assumptions. And as I said, this lack of complex understanding. It's a failure to acknowledge the basic biology of this red cell storage defect, which I think Nathaniel also mentions. It's got biases at all levels of research. I'm going to go into some of those biases here in just a couple of minutes, because I think the biases continue to block us from moving forward. And there's been a systemic worldwide blockade of oxygen therapeutic agents leading to regulatory approval. Thousands, tens of thousands of patients have received them safely, and yet the major agencies in the Western world have refused to understand a way to do research effectively showing that their utilization could be useful in patients where blood is not an option. And that is to the detriment of billions of people. I think billions of people have their health care at risk because we, the Western world, has been myopic in viewing our regulations are only for ourselves. Our regulations change the entire world. So the World Health Organization and Axel Hoffman and all the committee that worked with him, and there's a long list of names of people that contributed to this. Thank you so much. This is one of the finest things I've ever read. They made a call for action in October of 2021 or September of 2021, and it lays out the fundamentals of PBM far better than I could. But to my knowledge, since that came out, little has changed. I pound my fist to get people to read this. Say, if you want to read one thing, read this outcome. I've sent it to people in the United States government. To date, nobody's beating down my door saying, how soon can we participate with the World Health Organization? Barry A. Shander, myself, many people on this call, all joined into a call for why we needed patient blood management with COVID. There was a worldwide shortage of blood available for transfusion when COVID came around. The methodology to take care of that problem was right in front of every government's face. Embrace patient blood management, wholeheartedly embrace it, teach it, force it to be into every one of your healthcare systems like the Australians have and they've done in Ontario and other places. But still, nobody embraced that, even though this was out in the world's literature. Evidence exists from Korea wherein you can trace COVID in one particular patient who went and donated blood, and that COVID showed up in a patient that received the blood transfusion. Evidence directly exists there, and it also exists in China, yet the Western world was unwilling to investigate whether COVID could be transmitted by blood transfusion. I can have that argument with anybody who wishes to have it, but the facts are there. They've wished to have their blinders on and not even investigate it. So here's a book that I would like to recommend to every last one of you to read. We all filter information in every part of our lives. Whatever information you get from news on television, and in the United States, we get bombarded with horrible different levels of arguments for and against all kinds of things. But we all have our believing brains. In other words, our brains are programmed to analyze and accept data based upon our own belief system. And that's absolutely true in science and in medicine as well. I read an article. I either accept the data in the article, and in some articles, I'm far more critical. Why? Because of what I have read before and what I have as a belief system. Having read this one book, I hope I can look a little bit better in the mirror and try to understand my own resistance to believing new data and accepting new people or accepting people's new facts or new visions of the world. But the believing brain is what has driven transfusion for 140 years. And it is the believing brain that has accepted only certain data and only certain protocols and guidelines and such. To those who hold a spiritual belief, it's real. It's a religion. I've coined the term that transfusion is a religion. Think about it. It really is a religion. Medical data are based on prevailing beliefs and systems of the day. Try getting a National Institutes of Health grant. When I went for my first $3.5 million National Institutes of Health grant, I proved outcome after heart surgery based upon whether or not patients were analyzed with TEG and viscoelastic whole blood testing. And I was laughed out of the National Institutes of Health. I was essentially told to please never reply to their granting agency again, because anybody in medicine knew that to use viscoelastic testing, you didn't know anything about medicine. So now there are over 17,000 articles on that test alone. So it's absolutely true that what is a prevailing thought in medicine at the time drives either what gets funded, what gets researched, and what gets published. But it goes further, and it's very subtle. And if you look into individual papers that are published, we repeat certain mantras, and those mantras that get repeated drive and feedback upon the belief system. There's a universal introduction in almost every transfusion paper, especially if the transfusion paper goes on to say things about patient blood management. And that introduction is, here it is in a very well-known paper by many well-known names, many of whom I know both personally and I consider to be friends. And by me putting this up here, I do not wish to destroy my friendship with them. But they say in the very first line of the first sentence of the paper is transfusion of red cells has saved countless lives owing to, and then they go on with a litany for half a page of why it saved lives. And that opening line is repeated in every transfusion paper I've seen. It's never referenced. There is no reference. There is no way to reference it. It is non-scientific. And when I review papers and I rail against that and I say, prove that to me, I get sent back or asked not to review papers again for that journal. So it is a situation wherein we're promulgating or promoting the same line of thinking, the same belief system, by forcing people who are going to publish anything by they must genuflect in front of the dogma. If you don't say the dogma in the opening paragraph, you don't get published. Makes you think. It cannot be proven. It's opinion. It's widespread opinion. It's lore and it's practice. Yet to get published, you have to repeat that gospel over and over and over again. And the scientific right now is profoundly the opposite. Indeed, the opposite is what we have now proved. We've spent billions of dollars proving exactly the opposite, that transfusion doesn't do these things. And PBM has evolved by not directly attacking the establishment. Is that correct? Well, I don't really know, and I can have that philosophical discussion, but we've been allowed to exist, bubble up, and develop because we haven't taken this head on with a wrestling match with the establishment. But why? Maybe otherwise we'd be squashed. Maybe we'd be burned at the stake as heretics. So quality improvement research is now focusing on reducing usage of RBCs, and transfusion. There's a huge amount of quality research that's coming out. There's a movement in surgery called ERAS, early recovery after surgery. That's a movement. And I just was a lead speaker at a meeting for ERAS, and I said, why does it astound me that now we have to have societies about doing what I thought we were all supposed to do as physicians, which was provide the earliest recovery for our patients at any possible time. Why do we have to spend money to teach people to do things that make sense to begin with? Wouldn't the lay public like to know that for the last 150 years we've been taking care of things that are easiest for the healthcare system? Maybe most expeditious, but now we have to have a society that actually advocates to get you out of the hospital as soon as possible. Wow, there's something basically wrong with that. So at any rate, in these articles that get published in manuscripts, they talk about reducing usage or dependency upon blood transfusion, or the need for blood transfusion. There is no need for blood transfusion. There is no dependency. It's a human behavior. So those words need to be stricken from our language, and they're part of the bias that shows up in every article that gets published. And by using those particular words, we continue to force the bias upon all of us. The vast majority of this literature that's now coming out in patient blood management supports improved outcomes with the less you transfuse, yet the attacks continue. Attacks continue in the literature against these bits, these wonderful papers. We're all familiar with Western Australia. We're all familiar with the On-Track program in Ontario. The dramatic differences both in cost savings and an improved outcome for those patients. Yet multiple studies agree that RBC transfusion and heart surgery increases mortality. Ron Salinger, who's at University of Maryland, one of the lead cardiac surgeon at the University of Maryland, is not only publishing on what the prevalence and utilization of blood is in heart surgery in the state of Maryland and what they call the the Maryland Quality Initiative. It's much like the state of Virginia. It's much like Ontario. It's much like Western Australia. Now it's catching on that individual states within the United States are looking at their own data. And what does Ron Salinger say? He says that blood transfusion is very tribal. In other words, every group in every hospital has their own behavior patterns, probably driven by the most powerful gray-haired old man that tells everybody else what to do. Maybe he's the most outspoken, or she's the most outspoken or most difficult person to work with. But that drives the behavior. And that's exactly what we saw in 1992 when I published my first article on it. Yes, the overall utilization of blood in heart surgery has decreased, but the discord between those who use the most and those who use the least has still occurred. But here's what Ron Salinger says. There's a 13% increase in 30-day mortality per unit of red blood cells used. 13% increase in mortality. Others have found, there are now 7 publications that I could put up here. Others have found up to 16%. So it's well over 10%. It's somewhere less than 20% increased in mortality, all comers for heart surgery for every unit of blood transfused, and it is arithmetically additive. So the more blood you get, the more death you get. Why is this consistent? Because it's true. We don't need randomized controlled trials to tell us that. We've got multiple bits of data all pointing in the direction. Yet the trick trials and the places where people have tried to do randomized controlled trials because they wish to trump and outplay every bit of retrospective data, they have been unable to either prove it wrong or to prove facts in the other direction. And this is data from Virginia, same kinds of thing. Now let's go to the trials that have been done, because the transfusion establishment says, well, you can't depend on retrospective data. Retrospective data is poor data. It's fraught with all kinds of compounding factors that may drive why you can't come to those conclusions. Except if you go to Bradford Hall's original discussion of evidence-based medicine, if all the data from retrospective flows in the same direction, it is the truth. And that's where we're at today. But now we have trials over and over and over again, and it appears that we're not done with them yet, to be randomized controlled trials. And so the very first one of these was Paul Hebert's original trick trial, which is now so famous. But isn't it amazing that he, in the first randomized controlled trial in critical care, showed that those in the restrictive transfusion group had a significantly lower mortality than those in the liberal transfusion group. So this got widely criticized as, well, you know, was it really the ultimate study? Was it really true? It happens to align with what the retrospective data is, but as soon as this data came out, the people who wish to support the bias and wish to support the thinking and transfusion went on a rampage of doing more and more randomized trials. Here's a review that came out in 2021, I believe, of a meta-analysis of 14 trials. The 12 of the 14 trials showed that there's no difference in outcome and mortality in those who are liberal versus those who are not, who are liberally transfused, those who are restrictive transfused. But their conclusion, since 2 trials had a hint, not highly statistically significant, but a hint of an improved outcome. Therefore, we need more trials. So we now have 72 randomized trials, including Trick 2, Trick 3, and now Trick 4 is undergoing. And those 72 trials have been promoted as randomized prospective examinations of patients who get a liberal utilization of blood versus a restrictive utilization of blood. When I have my discussions with these people who are running these trials, they say, hey, we need to know. No, what they wish to know is to find one positive outcome in their entire level of research, of which they can hang their hat on to then say, see, I told you so. See, in this one trial out of 72, 75, 100, 300 trials, whatever it's going to take, we had one trial that showed that it improved outcome. Therefore, all the rest of the literature is useless. Wait a minute, really? Is that science? Is that doing things right? Because, and this is out of the TRIC-3 trial, one small group of patients undergoing cardiac surgery, less than 65 years old, what was called the young ones. And to me now today, being over 65, I consider them to be the young ones. Those young ones actually had a tendency to have a lower mortality if they were transfused more liberally than those who weren't. And so they've now proposed the TRIC-4 trial. And I have to ask, what's your definition of futility? We got 72 trials that have been done with liberal versus restrictive blood transfusion. Each study has cost, in my estimation, I don't know the cost of each one, but they're millions of dollars to do these large randomized controlled trials. I bet some of them were pushing $20 million to do the study. So now there's 74 because we've got new ones proposed. I put the estimate at close to $500 million US to do these studies to prove to themselves that blood transfusion actually improves outcome. Yet they've been unable to prove that out of 72. How many more do we need? Do we need 100? Do we need 500? And if they find one out of 500 and the other 499 show no difference, does that then prove in their minds or in anybody's mind scientifically support for that original sentence that I said in every medical literature? So TRIC-4 is now an international, multi-center, open-labeled, randomized controlled trial of two commonly used transfusion studies in moderate high-risk patients, 65 years old or younger. And this is what's on clinicaltrials.gov and registered. And I've said to the people who are running it, why are you doing this? Well, we have to. They said, we have to. There's a signal there that perhaps transfusion actually does something. So you're on a crusade. You're on a crusade to find some slim piece of evidence that upholds your belief system. Is it possible to actually do this research? Of course it is. The reason I'm told by the people who design these studies that they are doing the studies the way they are is because you can't do a study wherein you withhold blood. So yes, you can. You can do a best of PBM study with the vast majority of those best of PBM patients getting no blood whatsoever and comparing that to standard therapy. Why can't you do that? Of course you can do that. I proposed doing that 4 times. Every time I've proposed doing that, I've been turned down on funding. It's a bias. It's an international bias in everybody's mind that they won't let anybody do it. And I can't just go to the National Institutes of Health in the United States for such a large trial without pilot data. So I need pilot data from 50 to 100 patients in one institution, and I propose doing it in bladder cancer patients for cystectomy. They're all anemic. They all are going to undergo a big blood loss procedure. Why don't we see if we treat their anemia, giving them the best of everything we possibly can in terms of PBM, see if and compare that to routine therapy and look at outcomes. I can write the paper right now, and I can guarantee you those who get PBM and those who get their anemia treated are going to do a whole lot better. So we continue to tilt at windmills. We search for the Holy Grail. Has that worked in 2,000 years of history? Not that I know of, but people still run around And when a popular movie comes out with somebody searching for the Holy Grail, everybody wants to go see it because that's what we're all after. We're all after searching for a Holy Grail. Monty Python did a great skit about it, and it's great comedy, but in the end, it's really very sad. The believing brain continues to try to search for the support of the data that supports what we believe. And to change that is really difficult. So there are no randomized trials of transfusion versus non-transfusion. I just said you can do them. And the people who've proposed the randomized trials that have been performed, they've had every right to change up how those randomized trials are doing. And every one of those comes out and somebody criticizes them and says, well, it wasn't the best trial. There was overlap between the groups. The real separation between the groups wasn't big enough. Well, the people who proposed them had every right to change them to make them correct to begin with, and they've never done it. So medicine is exhibiting a profound hypocrisy, and they're not really looking for the answers. They're looking to support the belief system that they've had founded and are promulgating and promoting and are pushing on our patients to the detriment of humanity. And the biggest assumption is that oxygen delivery is dependent upon hemoglobin concentration. That is wrong. It's not true. And more hemoglobin is not necessarily good, and transfusion actually makes it worse, not better. So Harry A. Shander did a fantastic job. I quote this paper. I push this paper to everybody that possibly can. That, yeah, anemia is really bad. And there's one way to treat anemia that's really simple. Let's give them a unit of blood. Your lab data looks better, but the patient is worse. And transfusion decisions are not taught in medical school. Why is this paper not taught as a series of lectures in medical school? I don't know. Listen to Dr. Majed Rafai's lecture on this Bloodless Medicine Society's website. He really looks at oxygen delivery and blood transfusion. Yeah, I could have given the lecture, but he does better. He focuses on it. He goes through all the data, and it's fantastic. Please embrace the society and promote the liberal thinking of that there's another way to look at the world. The storage lesion is a disaster upon the ecosystem. Giving stored blood induces a wildfire within the recipient. I'm not going to go into it in a large way, but tissue oxygen delivery is extremely complex. This is some of my work and some other people's work. Ivo Torres Fio, Kevin Ward, others, Roland Pittman, great physiologists looking at oxygen delivery. We found that critical delivery of oxygen to tissue is not reached until you are below 3 to 4 grams per deciliter of hemoglobin. Heme dilution alone in my lab to get to that level takes 13 volume dilutions to reach mortality. Yes, you have to hemodilute the animal 13 times. In other words, do an exchange transfusion where you take out red cells and you give them back albumin and saline, and you get them down to below 1 gram per deciliter of hemoglobin. That's when death arrives. It doesn't arrive at 7 grams per deciliter, 10 grams per deciliter. It's a whole lot lower. So I'm sorry, when this transpired on my computer, it doesn't all line up exactly right. But this is data that I love out of the Cleveland Clinic and Jehovah's Witnesses. Denton Cooley's work was mentioned. And those patients who refuse transfusion, a human experiment, by and of themselves saying, you know what, I'm going to opt out of this therapy. They do better. And so let me get to the end here. Because I think I'm starting to run out of time. Mother Nature is biologic complexity. Red cells are affected by oxidative stress, and red cells don't do well when you leave them in the refrigerator and they undergo oxidative stress and they get worse and worse and worse. And when we give them, it's not just the immune system, it's the fact that you're giving oxidatively stressed red cells that just can't possibly function well. So the key to bloodless medicine is never let a patient get near either the fatal hemoglobin or what I say is the fatal hemoglobin, which is the hemoglobin that triggers the behavior pattern in the human who's going to call the blood bank to give the blood transfusion. In other words, treat the anemia, do all the things you can to keep away from that dependency. There's that bad word, dependency upon blood transfusion. They all do as well or better until you get shock. In other words, extremely low perfusion, extremely low ability to move plasma and to perfuse cells. And let me go to my last point and I'll take questions. There's a worldwide need for a safe liquid oxygen carrier, what we used to call a blood substitute. Several are available. Large human trials have been done. I believe Russia has one, though I'm not exactly going to go ask anybody over there right now. I know China has one. China has a perfluorocarbon because I know they grabbed one that was being investigated in the United States. But US regulatory and European regulatory groups have refused to find a way forward to do the research necessary for when blood is not an option. And I've personally pushed high with people very highly connected, both inside the United States government, and it's actually been on Vladimir Zelensky's desk to get one of these products up to the front lines of the Ukraine. So far that hasn't happened, but maybe I'm not done yet with that. And the emerging world that is struggling to try to promote Western blood banking could utilize these technologies absolutely. But it's the transfusion bias that's killing human beings. It's the transfusion bias that I talked about so far that is not allowing us to find ways collectively to do the research to prove that these are either necessary, useful, etc. But it is that bias in the believing brain across all of medicine that somehow we have to attack. I've always been a heretic, you know that. I said this last year. So far, I haven't been burned at the stake, but I've been labeled all kinds of things. I've been told to my face I'm a fringe element. You, sir, are a fringe element. Okay, you want to define that? If that's what you want to define, fine, I'm a fringe element. I like my fringe element. I like speaking my mind. I like trying to look in that mirror and say, can you say that with truth? What is truth? Is truth just what I believe? Or is that something that, scientifically I can prove? So heretics attack institutions that are on shaky ground. The utilization of blood for the vast majority of places that it's utilized is on very, very shaky ground. Read Arieh Shanders and other people's analysis of how often blood products meet standards of care. Those are today's standards of care. Those are not. So there's only 15% or so of all transfusions that meet present day standards of care. What about the other 15%? Were they really necessary? Or were they just ones that we couldn't improve? Bloodless medicine must be our goal. And I'm going to leave you with this thought. And take this thought for all the rest of the lectures. And it goes to the believing brain. Faced with a choice between changing one's mind and proving that there's no need to do so, almost every one of us gets busy going on the proof. John Kenneth Galbraith. What do we believe? What's truth? And what is and what could be accomplished? So I believe strongly that bloodless medicine is our goal. And to get there, we've got a whole lot more education and a lot more looking in the mirror for every last one of us. Thank you. And I don't know how you're fixed on time, but it's 5 o'clock in the morning where I live. So I wouldn't mind after questions having a cup of coffee before I rejoin you, but I'd gladly take some questions if there are a few questions. Thank you.
Thank you, Dr. Bruce Spies. That was a wonderful talk. Yes, indeed. Bloodless medicine is a superior form of healthcare. And I'm sure all of you have many questions, but can we leave the questions to after all 3 talks? Is that okay, Dr. Bruce?
Yeah, I'll try to come back at that time and dial in for you again. Okay, I'm gonna go grab a cup of coffee and then come back and join you as soon as I can.
Okay, thank you so much.
Okay,
And,
thank you.
Thank you. I think Prof. Nim has joined us, and before we go on to the next presentation, can I have Prof. Nim to give his welcome address? Prof. Nim is the Provost for the College of Medicine, University of Calabar, Nigeria. Prof. Nim, floor is yours. Is Prof. Nim available? Sharon?
It seems to be off again.
Right.
Okay.
Can anyone
All
say
right.
he'll come back?
So, yeah, okay, he'll come back. We'll wait. Whenever he comes back, we'll let him say his welcome address. So we move on, right, on to the next presentation on intravenous iron therapy, practical points for the clinician, which will be given by Professor Dr. Manuel Munoz. Dr. Munoz is a professor in the Department of Surgical Specialties, Biochemistry and Immunology, School of Medicine, University of Malaga, Spain. Since 2000, Dr. Munoz has been actively researching patient blood management strategies with emphasis on perioperative anemia management, bleeding control, and cell salvage. I'm sure you've seen his name on a lot of papers. He has over 200 publications in this field, including original research, reviews, and consensus statements and book chapters. So Dr. Manuel Munoz, the floor is yours. We have much to learn from you. Dr. Munoz?
I do see him on. He appears to be muted. Dr. Munoz?
Yes, he's here. He just didn't turn on his video, which is affecting. We're asking to start his video.
Dr. Munoz. Mm-hmm.
Hello.
Hi. Dr. Munoz, you're on.
I'm right.
Yeah, you're on.
Okay. Is my presentation should be sharing now?
Yes, go ahead and share screen.
Okay. First of all, welcome everyone to this interesting meeting. And thank you very much to the organization for inviting me to participate. Well, the topic today is intravenous iron therapy, a practical point for clinicians. But I will not give a technical talk, but I will try to integrate this within the treatment of anemia, and I will explain you why. These are my conflict of interest. You can read it. I've been working with several pharmaceutical companies. And here,
Not sharing yet.
sorry?
Can you
Yes,
share your
like-
screen? Yeah.
You don't see the presentation?
No, we cannot see.
You have to click on share your screen at the bottom of your screen now.
It's a green box. Yeah.
Aha.
Okay.
Now?
It's gone. Yep, you're on.
Yeah.
Okay. The main problem is can be reflected in this paper that is almost 10 years ago. is over 16,000 consecutive patients undergoing cardiac surgery and at a single center. And they found that compared to patients that have not massive bleeding or red blood transfusion, those who has major bleeding or transfusion have 3 times the risk for perioperative mortality. And this risk increased up to 9-fold when both conditions are present. They have a major blood loss and red cell transfusion. But on top of this, if the patient presents with the preoperative anemia, the risk is further increased. So the conclusion of the author was that the major bleeding is per se a risk factor for perioperative mortality, which is potentiated by red blood cell transfusion and to a lesser extent by anemia. But one can think, well, it's only a little bit more. But if you go to a recent meta-analysis of the 24 studies, including over 1 million patients, they found that the prevalence of anemia was around 39%, and compared to the non-anemic patients, those who present with the preoperative anemia have a higher risk of acute lung injury, stroke, postoperative infection, postoperative mortality, and five-fold risk of transfusion. So it is important. And preoperative anemia is frequent, and it led to a worse outcome in the patient. So the clinical problem we have is that the preoperative anemia, perioperative blood loss, and allogeneic blood transfusion work together to produce a poor clinical outcome in the patient. And what is the solution we have for this problem? Well, the solution we are implementing now, mostly in Europe, it's patient blood management. Like with this, the previous speaker, the Dr. Spies, have clearly defined as a step in the way to bloodless medicine. And well, all you know that patient blood management is based on 3 pillars. When it's a preoperative stimulation of erythropoiesis, reduction of blood loss, and harness the anemia tolerance. That will allow us to reduce the transfusion rate, and in most of the cases to avoid transfusion completely. But it is important to note that avoiding transfusion is not the target of patient blood management. The target of patient blood management is to improve the clinical outcomes. And well, we know that by reducing transfusion, we will improve the clinical outcome. And it's something that we will get when we establish the whole process. The most difficult part of the implementation of patient blood management is the management of perioperative anemia. And we needed to treat it with iron, vitamin B12, folate, and EPOs. But before that, we need to do a right diagnosis and do it timely. So, a few years ago, we joined a group of, let's say, experts to develop a consensus statement on how to manage perioperative anemia and an iron deficiency. And we produced an algorithm that we believe that can facilitate the management of patients. The algorithm starts when the patient is listed for surgery, and then we have to ask a simple question: do the transfusion risk is higher than 10%, or the estimated blood loss higher than 500 ml. If the response is not, then we can do understand the preoperative evaluation and proceed to surgery. But if the response is yes, then we have to understand laboratory work up to identify the presence of anemia and to classify it in order to give the appropriate treatment. So what we will need a fluid blood count, reticulocyte, iron parameters, vitamin B12 and folate, inflammatory marker like C-reactive protein and creatinine, or estimated glomerular filtration rate. With this parameter, we can classify most of the anemia in the surgical patients. Well, when we receive the results, we can see, well, the preoperative hemoglobin is below 130 for both men and women. No. Is there any hematinic deficiency? No, then we can proceed to surgery. If yes, and especially it is the iron deficiency, we have to prescribe a supplement because there has been described an association between iron deficiency and a poor outcome in cardiac surgery and in intensive care patients. When we prescribe the supplement, we can proceed to surgery. But if the patient have a hemoglobin level of less than 130, then we have to decide we are facing an elective surgery, and then we have to classify the anemia and start with the treatment. And this is the way we do it. We have an anemic patient. The first thing we look at is to the iron test. If there is an alteration of the iron test, we can define an iron deficiency anemia, an anemia of chronic disease with iron deficiency, or an anemia of chronic inflammation. If the iron tests are normal, then we look to the vitamin B12 and folate levels. If they are low, we are facing megaloblastic anemia. If they are normal, there must be another kind of anemia, including renal, endocrine, drug, malignancy. And finally, in some patient will arrive to the diagnosis of is an anemia of unknown cause, because we don't have any more laboratory tests to classify it. So this is this algorithm working? We tried this in a retrospective series of over 3,000 patients from 5 Spanish centers undergoing 6 frequent surgical interventions. And what we found is that the prevalence of anemia was 36%, using an hemoglobin cutoff of 30 grams per deciliter for both genders. This is important. And regarding the hematinic status, we found that around 70% of anemic patients presented with absolute or functional iron deficiency, 40% of non-anemic patients presented with absolute or functional iron deficiency, and 40% of all patients present with low iron store, as defined by the erythropoietin below 100 and a transferrin saturation about 20. That means that the patient have not iron deficiency, but they have not enough iron in the store to recover from the bleeding caused by the surgery. And all these patients can benefit for iron therapy. In contrast, the folate vitamin B12 deficiency was much lower, less than 10%, and curiously, it was more frequent in non-anemic patients than in anemic patients. So, if we are going to treat iron deficiency, the first option is to use oral iron salt. They are cheap, easy to provide, but they have a lot of gastrointestinal side effects that can compromise the tolerance and the adherence to the treatment. And finally, the efficacy, especially if patients have some inflammation. So we only recommended this therapy for mild iron deficiency anemia, for non-anemic iron deficiency or low iron store, provided that we have between 6 and 8 weeks preoperative leave to treat the patient. And when we do so, we recommend daily doses of 40 to 50 milligrams of elemental iron per day, or moderate doses of 80 to 100 milligrams every other day. This way, we can increase the fractional absorption without compromising the efficacy and the safety. On the contrary, the administration of oral iron salt is not recommended for the treatment of postoperative anemia because the high level of oxygen after surgery will avoid the intestinal absorption of the iron, and therefore IV iron is recommended in this patient. The other option is IV iron formulation, and that modern iron formulation are safe, and the European Medicine Agency stated a few years ago that there is not different in the safety profile between all marketed IV iron formulation, but still there is an infusion reaction that can occur in approximately 1 in 200 patients. The anaphylaxis risk is very, very low, but still we need the venipuncture to administrate the compound, and obviously they are more costly than oral iron salts. However, IV iron has emerged as a safe an effective alternative to oral iron for treating iron deficiency anemia, especially in case of intolerance or contraindication to oral iron. And of course, it is refractoriness to oral iron. In patients with inflammation, because IV iron can bypass the hepcidin blockade, when the patient have moderate to severe anemia, because we will provide enough iron to correct it. In patients with ongoing blood loss, because oral iron will not keep with the need of iron. When we use erythropoietin stimulating agent, it has been demonstrated that the response to exogenous EPO is better when we give IV iron than when we oral iron. In patients with moderate to high surgical blood loss, and when we have a short time to major surgery, that means when we have less than 4 weeks to surgery, we need to use IV iron to treat iron deficiency. And this is it's also important that even when we have a short time, even if we don't have 3 weeks or 2 weeks, we have to always classify it and treat the anemia. I will show you some data later. Nevertheless, there is some important issues regarding IV iron that we have to keep in mind. The first thing is that the IV iron is not a magic bullet. You cannot expect that you can rise the hemoglobin a few days after the administration of IV iron. Within a few days, you will feel an improvement in well-being. In 1-2 weeks, we will see an increase in reticulocyte count and subsequently an hemoglobin increase. And in 1 month, we will see the normalization of ferritin and hemoglobin, if we are lucky. Not always is that the case. So we don't have to think that because we are giving IV, it will work in a few days. It will take several weeks to get the full response. And this has been very nicely proved in this study by NIF, published in Blood Transfusion 2 years ago. They treat 400 anemic surgical patients with ferric maltose at doses of between 500 or over 1,000, and they found that the maximum response to IV iron in terms of hemoglobin increase was seen between 26 and 30 days after the IV iron administration. So again, it's a time frame of 4 weeks, 1 month is the ideal for getting the appropriate response. Also, we have to take into account the effect of anemia severity. In this study of 84 anemic patients with iron deficiency or functional iron deficiency, we administered iron sucrose, doses of 800 to 1200 milligram over 4 to 6 weeks preoperatively. And we will see that there was a nice response according to the baseline hemoglobin. The lowest the baseline hemoglobin, the highest the response to IV iron. And that was particularly obvious for women scheduled for hysterectomy because they have let's say the more pure iron deficiency anemia with low degrees of inflammation. So some of these women increase between 3 and 5 gram per deciliter their hemoglobin concentration in 4-6 weeks. The response was a bit less in the arthroplastic group because they have some kind of component of inflammation, and obviously was less evident when we treat colorectal cancer because of the combination of iron deficiency, inflammation, and blood loss. Later on, ferric maltose was introduced in Spain, and we repeat the same study, but using ferric maltose, and we observed that the final response, the hemoglobin increment, was similar. At the response rate and the anemia correction rate was similar between the two compounds. The only difference we saw was the allogeneic blood transfusion was lower in the ferric maltose group, but it was accounted by the colon cancer patient. This patient received more IV iron than in the previous series, and they were more. They have more laparoscopic intervention than in the previous series. But probably the most interesting thing is that we are right to the same hemoglobin increase, but with much low, with fewer sessions. So we need 5 sessions, a minimum of 5 sessions to treat the patient with iron sucrose, and only 2 sessions to treat the patient with ferric maltose. That facilitates the treatment a lot and also compensate the increased acquisition cost of ferric maltose. So then, if we arrive to the same point, what is different to use the iron sucrose or ferric maltose or any other high dose iron? Well, this is the normal way that iron is moving in our body. We have iron in the store, and every single day, 25 milligrams are needed to replace the the red blood cells by the bone marrow. Now, this 25 milligrams come out from the store through the ferroportin. This is the only known iron exporter we have in the human body, and with this amount of iron, we got a transferrin saturation of around 30-35%. When we have inflammation, hepcidin provokes internalization and destruction of ferroportin, so the flow of iron from the macrophage to the transferrin is reduced to around 50 milligrams per day. That means that we found a transferrin saturation below 20. If we give several doses of IV iron with a compound that allow for low dosage infusion, we will provoke an iron overload inside the macrophage. And the macrophage will respond, increasing the expression of ferroportin, and this will counterbalance the inhibition of provoked by hepcidin, so we can increase the amount of iron that is being released to the circulation, and we can restore the transferrin saturation. Interestingly, we can get the same effect when we do have a high dose compound, and when we are able to administer 1,000 milligrams or more. So we can get the same effect, but just in one session, and it again facilitates a lot of treatment. So which iron formulation we can use? Well, I don't know how it's the situation in your area, but for instance, in Spain, you cannot decide which type formulation you can use. It's just the one that had been acquired by the hospital. But if iron sucrose was the first one we used, and it's even today is widely used. You can give it at low doses, only 200 milligrams per session, with a maximum of 300 milligrams per week. So you require multiple infusions to give to the patient 1 gram. And we have to take care about the alkaline pH of this preparation. And so we have to be very careful not to produce extravasation of the compound, because it will be very painful for the patient. Later, we have a ferricable maltose. It can give a high dose, 20 milligrams per kilogram, with a maximum of 1,000 milligrams per session in Europe, 750 milligrams in US. This can be given over 15 minutes. This compound have a very low concentration of free iron, so the infusion reactions are less frequent than with iron sucrose. But ferricable maltose have the problem of hypophosphatemia that can be presented in up to 50-70% of patients. Not always are clinically relevant, but it is a problem. But we don't. We have to face, and we don't know exactly how to manage. More recently, there is a new compound that is there is a maltose that also can be given a high dose of 20 milligrams per kilogram, with a maximum of 2,000 milligrams per session. That means that we can satisfy the need of iron from the majority of our patient. It can be given between 15 and 30 minutes. Again, this formulation has a low free iron, and we are getting growing experience on the use of this formulation in surgical patients. Last but not least, that is a relatively old molecule, this low molecular weight iron dextran, that also can be given a high dosage, 20 milligram per kilogram. There is not top dose. You can give the total iron. You can cover the total iron deficiency in one session. The problem is that you need between 4 and 6 hours to give the total iron, to make a total iron infusion. But the advantage is that it's a very low price. It's 1/5 the price of a vertical maltose or ferric maltose. So we can balance the two things. Just talking about the total iron infusion with Michael Auerbach. This is an oncohematologist from the US that probably most of you know. We were discussing if we really need to give such a big amount of iron to the patient in one sitting. And I convinced him, and he tried to do a smaller dose of just 1 gram, but in a shorter time, 1 hour. So these are the data from almost 400 consecutive anemic patients, mostly with heavy uterine bleeding or gastrointestinal bleeding. This patient received 570 infusion of 1 gram low molecular weight iron dextran on a median time of 63 minutes. Only 10 patients were pre-medicated with prednisolone. The mean hemoglobin increase was 1.1 gram per deciliter at 4 weeks. Of those patients, 55% have an hemoglobin increase equal or higher than 1 gram, and 26% equal or higher to 2 grams per deciliter. There were very few adverse events, only 6.5%, more frequently among patients that have allergy to some medicaments, and only 7 of them need to be treated with methylprednisolone, and 2 of them were treated with acetaminophen. There were no severe adverse side effects, though the author believed that, well, because the low incidence of this kind of adverse event, they will need at least to include 3,000 patients to find one. So the conclusion is a bit limited with that. But altogether, what said, this is a compound that can effectively and safely treat anemia in the preoperative period, and with the advantage that we can the acquisition cost is much lower than the other ones, and I think that a 1 hour infusion time is something that can be assumed by any hospital. So when we have classified anemia and started treatment, we have to think about to postpone surgery until the patient is no longer anemic, or at least we get a reasonable hemoglobin level according to the intervention. If we have talking about non-elective surgery, we still can classify the anemia and start the treatment, and then proceed to surgery. The treatment can be completed after surgery while the patient is in the hospital. This is our data on over 500 anemic women with sustaining hip fracture. And you can see that compared to the control, those receiving IV iron or IV iron placebo show a lower transfusion rate. But we were not completely satisfied with this result, and then we reanalyzed the data according to baseline hemoglobin, and then we found that really the group that benefit, that significantly benefit from this treatment strategy, were the women with hemoglobin between 12 and 13, that according to who were non-anemic, but according to the most recent guideline, they are. So this is one more reason to use the same hemoglobin cutoff for defining anemia in the surgical setting. No women discrimination in this area, and a cutoff of 13 for both genders. Most probably we can improve further this result adding tranexamic acid, and in this regard there is a recent trial that has been finished, the HIFI trial, comparing the use of tranexamic acid with IV iron and IV iron plus EPO, either alone or as a combined treatment. And the patients that receive IV iron plus EPO plus tranexamic acid really displayed a very, very low rate of transfusion. So we are waiting for the publication with the preliminary results were presented at the last NATO meeting and are quite promising. So if you want to go a little bit further on the problems and question about IV iron treatment, I recommended these two publications. One is the current misconceptions and the diagnosis of iron deficiency. And the other one is the prevention and management of acute reaction to intravenous iron in the surgical patient. So I must say that most of the reactions that we see are infusion reactions that are cell limited. They don't need treatment, just to stop the infusion, wait for a few minutes, and restart to a much lower rate. We have seen that IV iron will provide a safe and rapid and effective way to treat iron deficiency in surgical patients, even when we have a short time. But sometimes it's difficult to organize that the patient receive IV iron. So there are a growing interest in newer iron formulation. One of these newer iron formulations is sucrosomal iron. That is a compound that is consists of a core of iron pyrophosphate, which is enclosed in a phospholipid matrix, and it's enveloped in a sequester matrix. The sequester is an absorption enhancer. Well, this is nanoparticulate a compound with a diameter of approximately 200 nanometer that is taken up by transcellular and endocytosis erodes. The endocytosis is mediated by the M cells. The M cells are a special cell that is close to the Peyer's patch in the intestine, and they are all along the whole intestine. So that means that the uptake of iron is not restricted to the duodenum and the jejunum, but it can occur along the whole gastrointestinal tract. And these mechanisms make that over 90% of the absorption is hepcidin independent, and then it's not affected by inflammation. Other particular thing is that the nanoparticles are taken up to the mostly to the lymphatic circulation. Then they will reach the blood circulation, will be taken up by the macrophages and the mantle, and the iron will be available for biological function. There are many studies using this compound in many different clinical settings, and there are a few studies that performed in the surgical area. This is one, a recent one, where the author checked the benefit of preoperative oral iron supplementation with sucrosumal iron in cardiac surgery, and they are analyzed the data according to baseline hemoglobin and gender. There were around 600 patients undergoing cardiac surgery. The patients were divided in two groups, receiving either oral sucrosumal iron 60 milligrams per day for 30 days prior to surgery, or standard care. And what they saw is that hemoglobin, preoperative hemoglobin or missing hemoglobin increased respect to baseline, especially in those with hemoglobin below 13, and with no difference between men and women. This increase in hemoglobin translates into a reduction in transfusion rate that was more pronounced in women, but still women have, even when treated, have a higher transfusion rate than men. And also this translated into a lower transfusion index. Less transfused patients receive less units when they were treated with sucrosumal iron. Again, you can see that women were more benefit, but still they have a higher transfusion rate than men. So it's seen that the group of patients that benefit the most from this therapy are those with hemoglobin below 13, and they also are planning now to combine this sucrosumal iron treatment with EPO. So probably what they do is just to select the population with hemoglobin below 30 and treat it with sucrosumal iron at 60 milligrams per day plus 1 or 2 doses of EPO in the preoperative period. Another point is that this center is a high volume center, so this the trial was complete in 2 years. So I hope that we can have the data for the new trial in a short time. Postoperative anemia is also important. It can affect up to 80-90% of patients, and most of the clinicians don't pay too much attention. We have seen for the previous lecture that the trial just focus on to use a restrictive of a liver transfusion protocol, but they forget about to treat anemia. So, and that's why the same group done before, we develop an international consensus on how to manage a postoperative anemia while the patient is in the hospital. So, in a privately, we consider that when the patient have iron deficiency after the surgery or have a hemoglobin below 10 grams per deciliter, you must consider the use of IV iron. If the patient have a severe anemia, even if it's not symptomatic, you have to consider IV iron supplement, and probably also the EPO supplementation, especially in those patients that decline to use to receive a transfusion. In symptomatic severe anemia, we consider we recommend to consider transfusion, the minimum amount possible. We know that most of the time 1 unit is enough, and don't forget that after transfusion the patient is still anemic. That's important, and then we have to treat it. There is several studies that showing that this therapy can be effective in reducing the transfusion rate and increasing hemoglobin. And because of the good result obtained with sucrosumal iron in administered preoperatively in cardiac surgery. They try to do it also after cardiac surgery. So this is a respective study of approximately 100 patients in two groups. One group received sucrosomal iron 120 milligrams per day for 10 days, and followed by 30 milligrams per day for another 10 days. Patients were recruited for the study approximately 10 days after surgery. And the other half of the patient received 1 gram of ferric maltose after treatment. And let's say that 1 month after surgery, you can see that, well, both treatments were effective. Hemoglobin level was slightly higher in the ferric maltose group. At the same, we will see for transfusion for transferrin saturation. And as expected, ferritin level will be much higher in the IV iron group. What this indicated is that oral succinylcholine iron could be effective in recovering from postoperative anemia, and perhaps we can either to increase the dose, not only 120 milligrams per day for 10 days, but we can extend this dose, or we can extend the time for treating the patient. So after a take-home message, I would say that please screen the presence of anemia as early as possible. If the patient have hemoglobin below 13 grams per deciliter, all the lab tests needed to classify the anemia and treat them. Many times we need to search for the cause of anemia. And don't forget that some patients can have a combined causes of anemia. It not need to be always ID, but it could be ID in combination with vitamin B12 or folate acid deficiency. According to the data from the lab, we have to tailor the treatment for the patient. The target should be an hemoglobin above 13. We have to consider the time we have to prepare the patient and how we are going to give the iron. We have the vitamin B12, folic acid, whether we need ESA or not. We have to consider if other treatments are necessary to facilitate the anemia treatment. And anytime that we treat an anemia that is severe or moderate, and especially if we stimulate the bone marrow with ESAs, we recommend to supplement also with folic acid and vitamin B12, because these are very cheap medicines with no side effects and can really improve the result when we treat the patient with IV iron and ESA. Don't forget the follow-up. We have to reevaluate the patient early before surgery with the idea to refine or the treatment or retreat the patient if necessary, and then after surgery we have to make an individual plan to follow up the patient, and don't forget to treat postoperative anemia. Thank you very much for your kind attention.
Well, thank you, Professor Munoz, for that very stimulating talk about IV iron. For all of us in bloodless medicine, we know that this has been a mainstay and our #1 staple in our bloodless toolbox. So thank you very much for that information. So as a natural follow-up to that, the erythropoietin is something that we also oftentimes use in conjunction with that. So I'm very happy to introduce our next speaker, who is a pharmacist and intimately knows the ins and outs of that therapy. So I would like to actually introduce to you at this time, pharmacist Onenya Izaguzo, who's an assistant director of pharmaceutical services in the Federal Medical Center in Owerri, Nigeria. She's an active member of the local Bloodless Medicine and Surgery group there in her institution. She's also a member of the Bloodless Medicine and Surgery Society. She's also a strong advocate for transfusion-free medicine at the medical. She's a strong and passionate advocate for transfusion-free medicine, and she's a patient's right advocate. So I'm going to turn now the program over to her. Thank you so much.
Thank you for that introduction. Thank you all for the opportunity to speak at this week's Bloodless Surgery program. I'll share my screen now.
Can someone help with the slides?
Can you share your screen? Down at the bottom, there's a little green box. You still with us? There you go. So just if you just put it in the slideshow view. At the top. Mhm. Yes. You just had it in the slides, in the slide view.
Are you seeing the slides now?
No, we were a few minutes ago. Hit share your screen again, perhaps?
Okay.
You see the little green box down at the bottom of your screen?
So if at last it doesn't work out, I think here we can share. Okay, good. We
Okay,
can
there you
share
go.
slides from here.
The slideshow doesn't want to start. I don't know why.
If you would
Okay.
like, we can share the slides for you.
Okay, go ahead. Okay. Take over.
Good, what is she saying?
No, it's paused.
Just give us one moment and we can share the slides for you.
We'll need to stop her share.
That's what it is. Can you see it now?
Yes, but there are some rectangles.
Okay, I'll move it.
Yeah, we can see it.
So go away as we continue. So sorry for that delay. So erythropoietin is a familiar name in bloodless medicine and surgery. So it's important that we talk about it, what it is, what it's used for, how it's produced. And we also want to look at other functions it might have in addition to optimizing the hematocrit. So what is erythropoietin? It's actually a glycoprotein hormone that is produced in the body, mainly in the adult kidney. And some is also produced in the fetal liver. Erythropoietin is a primary regulator of erythropoiesis. It is not the sole factor responsible for erythropoiesis. There are still other factors that are responsible for erythropoiesis. However, it is the primary regulator. Its main stimulus, the main stimulus for its production is kidney hypoxia. And it acts mainly on the committed erythroid progenitor cells, with the boss-forming unit erythroid cells and the colony-forming unit erythroid cells are the ones that show high dependency and more expression for erythropoietin receptors. Once it acts on these cells, it stimulates their proliferation and differentiation into mature red blood cells. So, how did we come to know about erythropoietin? The story behind it started about a century ago. There are some French investigators that realized that a small amount of plasma gotten from anemic rabbits that were injected into normal animals caused an increase in red blood cell production within a few hours. They were interested in this activity and they referred to it as hemopoietin. They wanted to understand more as to what caused this activity. And this investigation led them to realize that a single protein was responsible. The protein was found in the blood plasma and that it was responsible for this action. Initially, it was referred to as an erythropoietic stimulating factor, but finally, it was given the name erythropoietin. More investigations were carried out by American investigators. They now refined the work of these French scientists and proved conclusively that there was a hormone responsible for that production, and that is erythropoietin. They continued investigations that now led them to understand this hormone better as to how it was produced, what stimulated the production, people who could benefit from it, and is there any other way to produce it outside the endogenous one? By 1983, they discovered a method for mass producing a synthetic version of that hormone. How is erythropoietin produced? We came to understand that erythropoietin was produced in the peritubular interstitial cells of the kidney under the control of a single gene on the human chromosome 7. The gene product is a protein containing about 193 amino acids. The first 27 are cleaved during secretion. And the final hormonal peptide is heavily glycosylated and has a molecular weight of approximately 30,400 Daltons. This erythropoietin, once produced, travels down to the marrow. At the bone marrow, we have the erythropoietin receptor sites, which are found on the surface of committed erythroid progenitors. Once it binds at that the receptor sites on this surface, committed erythroid progenitor cells, it becomes internalized. At this, we also want to understand that there is an inverse correlation between tissue oxygenation and circulating EPO levels. Once the tissue oxygenation is normal or optimum, the circulating erythropoietin levels will be low. But once there is hypoxia, there is increase in the circulating erythropoietin levels, since anemia or hypoxemia would cause increase in renal synthesis of erythropoietin. So the serum erythropoietin levels will rise. Marrow progenitor cell survival, proliferation, and maturation will also be dramatically stimulated. However, this finely tuned feedback mechanism could be disrupted at any point. We've seen that it's mainly produced in the kidney. If there is a problem with the kidney, or there is a damage to the bone marrow, or maybe there is a problem or a deficiency in iron or the other essential vitamins that are responsible for the production of red blood cells, this finely tuned back loop could be disrupted and there will be problems. Also, when there is an inflammation, in inflammatory states, we realize that erythropoietin secretion is usually suppressed by the inflammatory cytokinins. Iron delivery and also progenitor proliferation are also suppressed by these inflammatory cytokinins. So what could be done? How do we help patients in this kind of state? These limitations to endogenous production led to more research that now brought about a technology that was able to overcome all these limitations. It's a technology that involved a combination of medical and molecular engineering. And this gave rise to the recombinant human erythropoietin. What is this recombinant human erythropoietin? It's a therapeutic agent produced by DNA technology in mammalian cell culture. We could say that it's a synthetic form of erythropoietin. And it's virtually identical to the naturally occurring hormone. That is the naturally occurring erythropoietin. There are about 5 types of these that have been synthesized over the years. We have the epoietin alpha, delta, the epoietin beta, the epoietin omega, delta, and the double epoietin alpha. All these agents have the same amino acid sequence, but their glycosylation varies as a result of the type and host cell specific differences in the production process. The epoietin alpha is the first recombinant erythropoietin to be synthesized, which happened in 1983 when the gene coding for erythropoietin was first identified by the American Genetic Research Corporation, Amgen. They patented the drug under the name Epogen. It has about 165 amino acids with a molecular weight of approximately 30,400 Daltons. You see that very similar to the endogenous one. And it was produced in mammalian cells into which the human erythropoietin gene had been introduced. This erythropoietin alpha is formulated as a colorless liquid in a solution of sodium chloride buffered with a sodium citrate or sodium phosphate. It's packaged for injection in 1 ml vials. It's a pre-filled injection. It comes, you can have the 2,000 international units, 4,000, even as high as the 10,000 international units of erythropoietin alpha. However, it has to be stored in the refrigerator between -20 degrees to -70 degrees. It doesn't need to be freezed because freezing would make it lose its efficacy. However, if heat denatures it, because we know it's a protein and heat could denature proteins. So we have to be careful whenever we are sourcing the epoietin or this recombinant erythropoietin, we have to be careful where we are getting it so that we do not get something that will not work. Then the next one to come into the scene is the epoietin beta, initially marketed as Recomon by a German company which became part of the Roche group. It's similar to epoietin alpha with respect to molecular characteristics and pharmacokinetic data. However, there are a few differences in that it has higher molecular weights and it also has lower number of silylated glycan residues. These differences could account for slight pharmacokinetic advantages, such as a longer terminal elimination half-life against the epoietin alpha. The epoietin beta is packaged in pre-filled syringes, just as the epoietin alpha, and it comes in these solutions with urea, sodium chloride, sodium phosphate, and water. That's all part of that injection. It also has to be stored cold chain, stored and transported cold chain, like every other recombinant epoietin. The third one that came into the world scene was erythropoietin omega, and is a sialoglycoprotein with smaller amounts of O-bond sugars. It has less acidic, and it's less acidic and has a different hydrophility than the other two erythropoietins. A study on efficacy and safety of this erythropoietin omega showed that its efficacy and safety is comparable, is as safe and as effective as the erythropoietin alpha. Then the next was the erythropoietin delta. This is quite unique. It was produced directly in a human cell line using gene activation technology. All the other ones, it was in mammalian cell cultures, but this is the only one that has a human type glycosylation profile. It is equally as effective as the erythropoietin alpha, and it was marketed, it was patented by the Shell Pharmaceutical Company, marketed as a Dynepo. However, by 2002, the European Medicine Agencies withdrew the authorization they gave to the company to market it, still under investigations as to why. Now we have the double erythropoietin alpha. This is a further re-engineered form of erythropoietin. Some changes were done, about 5 amino acid changes, which now resulted in the creation of 2 new sites for end-linked carbohydrate additions. And these modifications made it to have a longer selling half-life compared to the alpha and the beta. And it has increased biological activity in vivo. It's marketed by Amgen under the trade name Aranex. How does erythropoietin act? Its main function is to recruit, maintain, and induce the differentiation of erythroid progenitor cells. The burst-forming unit erythroid are the most primitive erythroid progenitor cells in the erythroid pathway. They are the ones that primarily respond first to erythropoietin. However, they require the synergistic action of erythropoietin with interleukin-3 or the granulocyte macrophage colony stimulating factor to start their differentiation into a colony of recognizable red blood cell precursors. Whereas the colony-forming units, they are completely dependent on erythropoietin for proliferation, viability, and differentiation. However, their dependence declines as the differentiation process proceeds through the late phase stage. The proerythroblast is usually which is a progeny of this colony-forming unit erythroid cells, is the earliest morphologically recognizable red blood cell precursor that is seen in the bone marrow. And it does not require erythropoietin for its maturation to reticulocytes. Then we move to the dosing and administration of erythropoietin. This table shows how the dose of erythropoietin alpha and beta is usually calculated, and it's dosed per kilogram of body weight per week. We see that the more the weight of the individual, the more units of erythropoietin that will be required to achieve good results. Then patients who do not respond to this initial dosing of about 4,000 units per kilogram per body weight, 450 units rather, patients who do not respond to this, they could receive double the dose. So it's very safe and they could still achieve the same efficacy results when the dose is doubled. Usually for erythropoietin alpha and beta 2, which are the 2 erythropoietins that are more in use, they are usually dosed between 100 to 150 units per kilogram body weight, given subcutaneously 2 times weekly. And this should be done for a period of 3 weeks. That's the patient should be receiving like 6 doses. And when you do this, you realize that erythropoiesis is increased to about 4 times the normal basal marrow red blood cell production. And we'll see reticulocyte counts by day 3 of administration of erythropoietin. The HB rise also is about 1 gram per DL every 4 to 7 days. For the long-acting erythropoietin stimulating agents, that's the dabopoietin alpha, you could either do weekly or give a bolus infusion in every 3 weeks. But like we've seen, there is no magic. You get better results when you start ahead of time. Whether erythropoietin is given subcutaneously or intravenously, it is usually well absorbed. However, the subcutaneous route is preferred. The reasons are clear. For the intravenous route, the peak serum concentration takes a shorter time to be achieved. But once it's achieved, usually within 1 hour of administering erythropoietin intravenously, you achieve the peak serum concentration, but it clears out of the system as fast as it's achieved, and hence its effect is not sustained for a longer time. Whereas for the subcutaneous route, the peak serum concentration duration is quite longer, and it declines, and for it to get eliminated, it declines slowly thereafter. That is why for the subcutaneous route, you have the half-life coming to about 24 hours, whereas the intravenous route, within 4 to 13 hours, it is cleared off the system. And since the subcutaneous route declines slowly thereafter, you realize that you require lower dosage to produce comparable effects as the intravenous route. A study was carried out whereby patients were given about 20 to 30% lower doses as that was given intravenously. And the results were very comparable as regards the efficacy. And with the subcutaneous route, there are lower incidence of adverse effects. It's clear why that will be so. It's also found to be more effective in hemodialysis patients, and it's more cost effective as lower doses are being used. When the volume of distribution was also examined, it was realized that it's similar to the plasma volume. So no matter what route you use, nothing is trapped in the tissues. Everything is available for use. What are the indications for erythropoietin therapy? One, we have the kidney disease patients. During the course of the introduction and its production, we've seen why these patients would require the recombinant erythropoietin as their body is not producing more. Then in AIDS patients who are on antiretroviral therapy, we have zidovudine as one of the antiretrovirals that cause anemia. Hence, patients receiving this medication would require the support of erythropoietin. Then perioperatively and in postoperative settings, when we want to stimulate patients' red blood cell production, erythropoietin is the drug of choice. In acute surgical and in the post-operation period, erythropoietin helps for more rapid recovery and is also a useful adjunct following perioperative hemodilation. In chemotherapy, some patients who are undergoing chemotherapy have chemotherapy-induced anemias, and erythropoietin could be very effective in these patients. Then, for patients who do not want allogenic blood transfusion, such patients would benefit from erythropoietin. Then in neonates, erythropoietin is also beneficial in the treatment of anemia of prematurity. In these neonates, erythropoietin showed good effects as regards there is overall benefit in developmental assessment and in cognitive development. It was also observed that it reduced both the morbidity and their mortality rates, as thrombolytic therapy is usually not preferred in this group of patients. However, erythropoietin effect goes beyond its use in optimizing the hematocrit. Erythropoietin has been seen to cause some multi-tissue responses associated with erythropoietin receptor expression in non-erythroid cells. Some of these cells include the endothelial cells, the brain cells, the skeletal muscles, the bone cells, the fat cells, and the heart cells. The expression of erythropoietin on the receptor of these cells has brought about good results. However, these studies have been carried out in animal models more than in human models. Then we want to look at the endothelial cells. The endothelial cells are the first cells to show erythropoietin activity beyond erythropoiesis. In the endothelial cells, we know that the endothelial nitric oxide synthase produces nitric oxide, which is a potent vasodilator. Erythropoietin has been found to stimulate these endothelial cells and activate the production of nitric oxide, particularly at reduced oxygen levels. And when this is done, we see that there is improved tissue oxygenation, as this provides a potential for an acute response, regulating vascular tone and blood pressure, because the nitric oxide opens up the vessel. So even when the blood volume is low, there is more being pumped in, and there is improved oxygen delivery. Then the cardioprotection. Erythropoietin, when studied in rats, proved to have cardioprotective effects. Some mice that lacked erythropoietin signaling, it was found that they exhibit ventricular hyperplasia, indicating defects in proliferation and expansion of the myocardium. Erythropoietin also promoted cardioprotection in ischemia perfusion injury in isolated adult hearts from rodents. Its administration in rabbits also was protective for myocardial infarction. In some adult rats, when erythropoietin was administered immediately after a myocardial infarction, it was noticed that the infarct size reduced, which was linked to opening up of new vessels by erythropoietin. It was also observed that delayed weekly erythropoietin treatment beginning 7 days after coronary occlusion in rats resulted in reduced injury and improved cardiac function associated with mobilized endothelial progenitor cells. Then, in the neurons, it was found out too that there are some erythropoietin receptors in the neurons and in some other locations in the brain. And the astrocytes and neurons in the brain cells, they produce erythropoietin in a hypoxia-inducible manner. It was also observed that animals that showed erythropoietin deletion in their neural cells exhibited reduced neural cell proliferation and viability, and also increased their susceptibility to glutamate damage and stroke. Erythropoietin preconditioning also proved to be protective for ischemia or middle cerebral artery occlusion, cerebral artery occlusion induced learning disability, and neuron death in animal brain. These studies were tried also in humans. The phase 1 clinical trial in humans with stroke showed promising results. However, when they moved on to the phase 2 and the phase 3 clinical trials, the results were not as favorable as the phase 1. Hence, more studies are required to show that erythropoietin could be neuroprotective in humans too. Then, in skeletal muscles, it was found out that erythropoietin stimulated myoblast proliferation and survival by increasing the DATF4 and the TAL1 that usually retarded myogenic differentiation. So, with erythropoietin stimulating this, myogenic differentiation was able to go on without being stopped. And hence, mice that were subjected to skeletal muscle injury exhibited improved muscle repair and recovery. And even the maximum load that could be tolerated by the isolated muscle was also increased. And this could explain why some athletes tend to abuse erythropoietin. Then, in the fat cells, animal studies showed that erythropoietin may also be protective in diet-induced obesity. We know that in diet-induced obesity, glucose tolerance usually is poor, and there is increase in insulin resistance, and there's also more fat mass accumulation. Erythropoietin was found to improve glucose tolerance reduce insulin resistance, and also regulate fat mass accumulation. However, this regulation in fat mass is gender specific. It happened particularly in the male mass. The reason is obvious. Estrogen is found in females, and estrogen can affect the action of erythropoietin through direct regulation of its production or even modulation of tissue-specific erythropoietin response. Hence, it couldn't regulate fat mass in females. Then, this effect of erythropoietin in adipocytes also led to understanding something that happens in residents of people who are residents at the high altitude. We know that for such people who reside at high altitude areas, there is lower oxygen tension, and as a result, the erythropoietin levels are quite higher. So we could explain why most of them, especially the males, are slimmer. And when we see the East African long distance runners, we see that they have no problem with obesity, and more of their males are on the slimmer side, not on the obese side. So this reduction in fat mass could be a reason for that. Then in the bone cells, erythropoietin was also found to improve bone healing. However, more studies also reveal that when erythropoietin is given in elevated doses, it could be detrimental to the bone formation. So the giving of erythropoietin, more studies need to be carried out in order to understand clearly at what dose would it help to improve the bone healing and repair, and at what dose could it be detrimental, since it resulted in significant bone reduction in some healthy animals who received this erythropoietin. Now, there are interactions with erythropoietin. Having seen all the sites, all the areas that erythropoietin could be effective. Yes, there are. We have both the food and the drug interactions. Foods that contain iron, folic acid, or vitamin B12, such as eggs, certain cereals, meats, and vegetables, they help, they can assist erythropoiesis, since these vitamins are all essential in erythropoiesis. So when a patient is receiving a poietin therapy and is on this kind of foods, there would be better, the results will come out better. Then vitamin A has also been found to increase the production of erythropoietin. So we expect that a patient who is on foods rich in vitamin A, like palm oil, carrots, sweet potatoes, cantaloupe, and is also on a poietin therapy, there will be a synergistic response. However, patients who have type 2 diabetes, when they are given fresh pomegranate juice, it was realized that it decreased their fasting serum erythropoietin. However, this result was not observed in normal patients. So it's mainly in patients with type 2 diabetes. So when they are on a poietin therapy, it will be better they avoid that juice. Drug interactions. Immunomodulatory agents like the lenalidomide, the pomalidomide, the thalidomide, when given concomitantly with erythropoietin, might increase the risk of thrombosis. Also, chemotherapeutic agents like doxorubicin, bicalutamide may also have the same effect when given concomitantly with erythropoietin. Whereas belzotifan was found to increase the adverse effects of erythropoietin. These are more major interactions. The minor interactions that were observed was seen in the angiotensin converting enzyme inhibitors like captopril, enalapril, perindopril, lisinopril. It was shown that they could decrease the serum concentration of erythropoietin. So patients who are receiving these medications or who might be given this medication because of the side effects of erythropoietin, this should be put into consideration. Then the C1 esterase inhibitors may also increase the risk of thrombosis, as they also have thrombogenic effects when given concomitantly with erythropoietin. However, parenteral iron preparations should be given with erythropoietin as it will improve its efficacy. We've seen how this production goes on. More synthesis of erythropoietin leads to increase in red blood cell production. And one of the important vitamins in red blood cell production is iron. So if there is increase in erythropoietin and you are not supplementing iron, you could trigger an iron deficiency in this patient. And from Prof. Stokes, we see that some patients, their iron stores might be very low, even though they are not anemic. So it's good to supplement equetin therapy with parenteral iron preparations. Iron supplements, whether oral too, could be very effective, but not when there is an acute, you are going in for surgery or there is an immediate need for increase in the blood, in red blood cell volume. So multivitamin supplements containing vitamin B12, folic acid, and vitamin A will also improve its efficacy. However, there are side effects associated with this equetin therapy. Usually it's observed that with intravenous erythropoietin, there is increase in blood pressure. This is thought to be as a result of rapid increase in the hematocrit. For that same reason, some patients may also develop clots, blood clots. This increase in blood pressure is not so common when the drug is administered subcutaneously. And it can also be managed with antihypertensive agents. Another side effect that was observed with erythropoietin is what we call the pure red cell aplasia. It's usually an autoimmune reaction that some patients had towards the recombinant human erythropoietin. But most studies show that this reaction may not be due to erythropoietin itself, but rather due to the effect of the leeches from the rubber stoppers that were used in the prefilled syringes. And some modifications were done to resolve these issues. And ever since then, newer cases of this pure red cell aplasia has become very, very rare. There are other minor side effects. They include diarrhea, dizziness, headache, itching, muscle aches and pains, nausea, vomiting, pain at the site of injection, tiredness. These side effects are usually seen when the patient just started receiving an administration of erythropoietin, but they gradually disappear as the patient's body adjusts to the medication. Contraindications. When a patient has hypertension and is uncontrolled, we've given antihypertensive agents and the blood pressure is not coming down, it will not be advisable to use erythropoietin. Patients with known hypersensitivity to mammalian cell-derived products would also react to erythropoietin, so it's contraindicated in such patients. Or patients that have known hypersensitivity to albumin, or patients that have coronary artery disease. In such patients, something that will increase the red blood cell production might cause the formation of clots, as their arteries are already narrowed. Then in iron deficiency anemia, erythropoietin is not the drug of choice. You have to treat the iron deficiency by giving a parenteral iron or oral iron, as the case may be. In anemia due to vitamin B12 or folate deficiency, erythropoietin would not be necessary in correcting this kind of anemia. And also in cases of porphyria, erythropoietin is usually contraindicated. So what are we taking home? We've seen that erythropoietin is a very important adjunct to intravenous iron in bloodless medicine and surgery. You can't talk about parenteral iron without talking about erythropoietin. Erythropoietin is wonderful. It optimizes both the hematocrit level and also the tissue oxygenation, which are two pillars in bloodless medicine and surgery. And these are what most surgeons are more interested in. But beyond optimizing the hematocrit, erythropoietin has shown that it could improve wound healing in burn cases for burn patients, and it could also improve platelet and leukocyte production. Erythropoietin has also demonstrated such effects as protection, neuroprotection, bone healing, and muscle repair. Also, reduction of fat deposition and accumulation, especially in males. Hence, we need to study more of this erythropoietin and on its effects and continue to use it as it has proved to be very useful. Thank you for listening.
Thank you, Ms. Onyinye Isiguzo. Wonderful, wonderful talk. We're always learning something new. There's always, something more to just erythropoietin. It's similar to iron, iron has also other benefits, neuro and myelination of nerves and cardioprotection and etc. So we have come to the end of all three splendid talks. Perhaps we open the floor to question and answer. Dr. Nathaniel, do you want to give your poll now, or shall we open the floor to question and answers?
Okay.
In joining us today, yeah.
Thank you very much, Jamil. And thank you to all the speakers so far. Apologies if we are overshooting a little bit, but let me just launch this few questions poll while we are aggregating the questions that were asked for answers. So please, can you see the poll questions?
Yes, we can.
Okay. So the first one, choose your continent. Let's see where our attendees are coming from. At a point, it looked like 100% Africa.
No,
It's changing.
it's not.
So I think it's possible to answer all of them before we then end the poll. Have you attended Bloodless Mercenary Surgery Week webinar before? And choose all types that apply to you.
Not letting me answer.
Did you enjoy today's webinar? Will you attend other days? Very encouraging answers. I think it's less than a minute, and I think virtually all the, let's see. Okay, still some more answers coming in. 4 out of, this is very interesting. Let's just allow 1 minute for Lydia. How about your lovely music? You can enjoy it for 15 seconds. Yeah. So I wanted to stop it, but answers are still coming in from what I'm seeing here, and I don't want to deprive anyone. Lydia, can you time us and help us? Thank you. So stop us when it's 1 minute. Take the time. 10:34.
There's a question to ask, why is Europe not in the option?
Oh, look at that. That's a major error. It seems like it was cut out. It was cut out at some point. I'm so sorry about that. It was there originally. Oh, wow. And we can't do this in between. Okay, you know what? We'll do it again tomorrow. So maybe I'll end the poll now, so that, because we don't have all the options for the first question.
Okay.
And I'll share the results. Are the results showing up?
Yes.
Yes, they are.
Yeah. And apologies to those in Europe. And so we do have a significant number from Africa. Maybe if Europe was there, then lots of people have been here before, but up to 25% have not been here before. Lots of HLCs, HIS, and physicians. Okay, thankfully there's pharmacists too, and others. And oh, 2 people did not enjoy it today, and 2 people said they won't come again. We apologize. We appreciate feedback. You could send us a mail to say what was done wrong. We'll repeat the poll as so I'll stop the sharing now.
Even someone from Antarctica, so maybe PBM and bloodless medicine is getting on the map there too now.
Okay, over to you.
Okay.
So, go ahead, Dr. Sadler.
Yeah, go ahead, Sharon. I think we need to introduce our 4 panelists, Dr. Carolyn Burns, Dr. Daniel Katz, Ms. Sandy Mann, and Dr. Marcus Inyama will join us today to answer some of the questions. And also, if you have any comments on the presentation, please feel free to do so.
So there were some questions about IV iron. One comment was made that since IV iron is not a magic bullet, in the case of emergency, someone wanted to know with a patient with severe anemia, can you still give IV iron? Can that be given? And if so, what iron formulation would be recommended?
Well, that is a 2-part question. It depends if you are talking about real emergency surgery that cannot be delayed. Then our recommendation is just to draw the blood sample to detect the anemia and classify, and start the treatment after surgery. If it's an urgent surgery that we can delay for 1-2 days, then we draw samples, classify the anemia, and give the IV iron, usually with EPO. In this case, don't give the full doses because you are not going to use it in such a short time, and you will lose a part of the drug with the bleeding, with the surgical bleeding. So give an initial dose of IV iron with EPO, and complete the treatment after surgery. And also you have to take into account the half-life of the compound. So in this case, we normally use iron sucrose because the half-life is much shorter. And so let's say in 48 hours, virtually there is not IV iron compound circulating. So you are not going to lose it during the surgery. If you use ferricarbosimatose, after 84 hours, you will have around 30% of the injected drug still on the circulation, and you may lose some. No problem with the EPO because we give it subcutaneously, so it's not going to be affected in a significant way by the bleeding.
Thank you very much for that answer. Maybe Dr. Marcus Inayama could comment to this. Someone wants to know how safe is IV iron in pregnancy?
Right?
Are you still there?
I don't get you.
The question.
How safe is IV iron in pregnancy?
Oh, well, at least in Europe, it's approved for to be used in the 2nd trimester or onward. It's not indicated in the 4th trimester, basically because it's not because a teratogenic, a possible teratogenic effect. It's just in the case that you have a severe reaction, well, you will compromise the fetus, the viability of the fetus. But it's approved to be given in the 2nd and 3rd trimester, especially in the 3rd trimester. And for women that they're not responding to oral iron, or are intolerant to oral iron in second trimester, and it's strongly recommended to be used in the third trimester when you diagnose the anemia in this at this time, because you will have no time to correct anemia before delivery if you use oral iron. And all the randomized controlled trials that have been done have not posed any safety concern of giving IV iron. Even there is a large trial performed in the United States on the use of low molecular weight iron dextran with no side effect in pregnant women.
Thank
I
you so
think
much.
Camila wanted to say something on that as well. Dr. Sata, did you indicate?
I was going to. No, I was just going to ask the other question. I mean, yes, in pregnancy, I mean, it's safe to give. And although there are no evidence whether it's safe in the first trimester, we tend to avoid it, but it's very safe in the second and third trimester. We give it routinely, yes, without much complications.
Well, I mean, we recommend to give iron supplementation from the beginning of pregnancy. So I think the only reason why they don't allow to give during the first trimester is just because of the risk of a possible anaphylactic reaction that could affect the fetus or the embryo by that time. So, but it's safe to use. There is not safety data. It's just more prevention than another thing. And there's another point regarding to use intramuscular iron or IV iron. I don't like intramuscular iron because the absorption is quite erratic. We don't know how much is absorbed. It's very painful. You got a wonderful tattoo. And also you can increase, and there's some data that can increase the risk of sarcoma. So, but if you don't have other way to treat it, give it IM.
Great. Dr. Spies, could you address 2 questions for us? Someone wants to know, how is it possible to practice bloodless medicine in rural areas? And also, too, earlier, there was some discussion back and forth about the concern for litigation in patients who are bloodless, as maybe a reason why organizations might not be so bloodless friendly or interested in implementing it. Could you address those 2 things?
Sure. First question I heard was about rural areas. Rural areas in Africa might be different than rural areas in Eastern Europe versus rural areas in the United States. One of the classic rural areas in the United States is talking about trauma in Western Texas, where it can be hundreds of miles between towns and even more hundreds of miles to a trauma center, et cetera. I think I don't have any universal answers to all those things, but I think the education of primary caregivers, just the way Dr. Munoz and others, and Izaguza, I'm going to mispronounce your name, but Izaguza was talking about, utilization of oral iron and IV iron. I think impressing upon primary caregivers, primary surgeons, primary obstetricians, et cetera, the necessity for not just accepting anemia, but attacking anemia as a disease in and of itself is vital. And that can be done whether you're in rural areas or not. Rural does not mean that you can't get medications. It just means that, you're a long ways from a central tertiary care, very fancy medical center, if you needed that kind of care. So I don't think there's any universal obstruction to it. There may be impediments to affording more expensive medications and medication availability, and that's going to change from one country to another and one town to another, probably, most of which I don't really know myself. In terms of the other question, which was litigation, I often get that. Litigation in itself is not an excuse or a right or a correct answer for bad medicine. Litigation and fear of litigation is a very wrong way to practice medicine and good care for our patients. The extensive use of litigation in my country has not produced anything positive that I can tell in terms of improving outcomes for our patients. All it's done is improved outcomes for the lawyers. Things like quality outcome databases run by various societies that look in what are called closed claim studies may be useful in terms of understanding where we see repetitive errors inside the medical care team. But litigation per se does not improve quality. Quality is the safest, cheapest thing you can do. That's what Toyota car company did and outcompeted the United States car industry in the 1970s and 1980s. They showed that by doing quality, you could outcompete anybody. So maybe you could say that a lesson that we're getting from litigation is that quality yet needs to improve, at least in my country. But the way to improve quality is not by just more and more litigation and fancy dollar awards. Maybe I'll stop just philosophizing there.
Could I dovetail, Bruce, on what you're saying a little bit? I think you're exactly right, and I completely agree. And there actually, in the United States, there have actually been some cases litigated due to the fact that transfusion was identified as part of that patient's ultimate morbidity and mortality. So we are seeing some litigation come for the exact opposite reason, that this patient that had harm due to that transfusion. So I think we have to, you're right, we have to get ourselves out of this whole concept, at least here in the United States, of practicing and in the country where that person is from, to get ourselves away from defensive medicine, because we cause more harm than good when we do that. And we have to try to expand, as everyone here that has been speaking today, the education that you all are providing, I think, helps us all when we communicate then with our colleagues, whether in our academic centers, in our larger urban areas, and out within our outreach communities. I too live in a state that is predominantly rural. We have 2 primary cities in the state of Kentucky, and very, very rural concepts and practices, very high levels of disease, and patients present at a very often end stage. But what I've been amazed at too is how we've basically normalized anemia, marginalized those patients with anemia, and therefore that adds into our disparity in our care. And so really getting our primary care physicians to realize at whatever stage that patient comes to you and presents, we need to ask the 50 whys and get those people where they need to be. And I think by communicating as well among ourselves and our patients, that leads to less litigation. So it all kind of comes full circle.
Yeah, and thanks, Carolyn. I think you and I agree on so many things in the world. I think the fact that primary care physicians don't aggressively go after anemia goes back to our medical education situation, which is that we don't teach about, blood as an organ, and that good blood health is really necessary. So we need to change that. Back to the litigation question, I've testified in a number of trials, and I think probably 3 or 4 times I've testified about questions regarding blood usage in operating rooms. And I've never been on the losing side of a lawsuit wherein somebody was sued because, quote unquote, if you had only given 1 more unit of blood, the patient would be alive. I've been in 3 or 4 of those, and never once has the physicians involved lost that lawsuit, because there's no data to say that 1 more unit of blood would have kept somebody alive. There just absolutely isn't. So, but yet I hear from physicians in my country, our country, all the time saying, I have to give 1 so that I don't get sued. That's not what you're going to get sued for. You are not going to get sued for that. That is absolute bunk.
Agreed.
So, going back to my philosophizing and me being up on the soapbox, if that's what somebody is putting forward to you as a reason for why they're transfusing, it goes to this bias that I talked about, and the bias, and they're using that as an excuse to cover up their bias that they don't know what the hell they're doing to begin with. And I'll say it as blatantly as that. I can't tell you the number of times I've given a lecture around the world on a podium and somebody comes up with that exact question is, well, I have to do it because otherwise I'm going to be sued. Please don't do that.
Thank you so much for that.
I'll bet in Africa you don't get sued so often.
I have never been sued. I practice bloodless medicine.
Right. How dare anybody to go after Nathaniel? I'll take him on.
I mean, since you've been working for the Department of Defense, I feel very secure.
Well, I'll tell you my proudest story in the Department of Defense was I trained 1,147 Special Forces medics. So these are men and women. Not so much U.S. Special Forces are women, but other NATO countries have Special Forces that are women. But these are men and women who had done 1 or 2 tours of duty of combat, usually in Afghanistan or Iraq when I was training them. They decided that they wished to not just be a Special Forces combat personnel, but they wished to also be a medic. So at least in NATO, every platoon carries a medic, and a Special Forces medic is trained for up to 40 weeks in a special training situation, and then goes back to their unit. I'm proud to say that I trained the Special Forces United States SEAL Team 6 gentleman who went on the Bin Laden raid and pronounced Bin Laden dead. So that was pretty cool. The colonel in charge of their unit called me shortly after the Bin Laden raid and said, "You trained him." And I said, "Oh, okay, I know who that was." So these people are trained to keep somebody alive in austere, remote parts of the world with major trauma with just what they carry on their back, and they have limited resources. You can't carry tens of liters of lactated ringers or albumin, so they have to have some pretty fantastic skills about understanding oxygen supply demand deficits and rotating tourniquets, compartmentalizing central perfusion of and doing things that other standard medicine just doesn't utilize.
I can see Caroline's hand up. I think she's concerned that you're giving out classified information.
Pardon, Nathaniel, I couldn't hear all of that. What?
Oh, I was saying that I could see Dr. Burns' hand is up, and I think she's concerned that Dr. Spies is giving out classified information, but she can't speak for herself.
No, I just forgot to take it down. No, not doing that.
Okay.
No classified leaks here, guaranteed.
We're okay.
So should we take maybe one or two more questions? So,
yes, please, let me just have an opportunity, if you don't mind,
mhm.
to remedy the one question that wasn't complete. So please, I crave your indulgence to now put in all those Europeans. We need them here. Because we were trying to form a delegation to speak to Professor Mungos to try and get more Europeans on the program. We have lots of Africans and North Americans. But lo and behold, okay, I think you can go on with the, oh, it's 100% answered now. So even though we are a bit fewer than when we started. Is it 100% answered? No, it's not. You can go on with the question while people are answering the poll.
So if Dr. Marcus Inanama could address this question, is there any difference between IV and IM administration of iron? We know you're one of the hematologists there at the center.
Sorry, I couldn't get you.
Okay.
Can you say it again?
The question is there any difference between IV, intravenous, and intramuscular administration of iron?
I think Professor
Intramuscular.
Mungos has given his opinion on that already.
Yes,
and
answered that.
it is now it is Marcos that wanted to say something, right?
Mm-hmm.
Okay. What Professor Munoz said is exactly what our experiences are. As a matter of fact, we don't give iron by intramuscular route at all. It's very risky. So there's no basis for comparison at all, since there's nothing to compare with in terms of outcomes. We only give intravenous iron when there is an indication. Otherwise, we give oral. Thank you.
Thank you. I think there's another question that's related to a comment that Dr. Spies made. We know he really gets us engaged there. Someone wanted to know, how would you be able to differentiate between calling a patient's death as related to transfusion as opposed to saying it wasn't because of their disease process?
Well, that's very complex, and there's no single overriding answer. You know, if you have coronary artery disease and you get a unit of blood, you actually make the heart more ischemic. If you have strokes or you have any number of brain problems and you give a unit of blood, the brain oxygen level will drop. So which is the disease or the transfusion or the interaction of the two? It's very hard to figure out. We're actually just have a paper accepted that I can't talk about in great depth, but at the University of Florida, they have a unique group that's looking at cognitive dysfunction during surgery and after surgery. I've looked at over 5,000 patients, and I challenged that group to say, okay, so let's look at anemia and the relationship of anemia to that. You won't believe how important anemia is to preoperative cognitive dysfunction. It is one of the single highest related disease processes to preoperative pre-Alzheimer's and Alzheimer's disease. Now, the next question that is asked, and there's a big NIH grant being written about it, is, so if you're anemic and you get transfused, do you come out of surgery a whole lot more confused and with a downhill slide in your cognition? So is it the transfusion? Is it the lack of treatment of anemia? Or is it the chronic inflammatory oxidative stress of the chronic disease? It's all of those things. How do you separate one from another? Difficult, very difficult. It depends on your bias, I guess.
Yeah. Transfusion death arising from transfusion at times could override the primary disease. So in such a way that it can be identified, such a death can be identified as being caused by transfusion. Yes, there is the immediate transfusion reaction that can cause death in a matter of minutes and to a few hours. And of course, there are the intermediate and long term. But as Professor Spies has said, it's quite difficult, but we have experienced where someone who has had surgery and just had a top-up transfusion, and within 3 hours, the person died. Those temporal relationships will tell us, because the surgery was essentially very successful, but immediately after the top-up transfusion was started, not halfway through, developed an acute transfusion reaction and died. Such ones we can definitely attribute the cause of transfusion or the cause of death to transfusion. But others where the cause of death to transfusion is the long-term side effect or reaction, it might be difficult to separate it from the primary disease. So I agree with what Professor Spies said.
And thanks, Marcus. This is where some of the retrospective data analysis has to come in. That, there's now 6 papers that show in cardiac surgery that transfusion is the #1 predictor of who's going to die in the hospital and over the next 5 years. The #1 predictor of who's going to die. So the Kaplan-Meier curves for those transfused versus those not transfused are dramatically different, and that goes out 5 years, and it keeps recurring and recurring and recurring, and you can and the people who don't believe in the data say, well, that's because they were more ill, they needed more transfusion. But then you go and you do very carefully propensity matched groups, and the transfusion stands out alone as the single largest predictor of who will die in 5 years. It's dramatic. It's like 4 or 5% difference. So was the transfusion the cause of death 5 years out? Hard to say. Leukemia, lymphomas occur more frequently in those patients transfused. The single largest cause that when the National Cancer Institute looked at it was transfusion for cabbage surgery in the early 1970s. Was it the transfusion that killed him? Or was it the lack of understanding in medicine? Difficult question.
That's answering it in a philosophical way, Professor Spies.
Just keep thinking about it. Go out for some nice long hikes somewhere, and you'll think about it. Maybe have a nice glass of red wine. Whatever your culture says is good for you. Go and enjoy it and think about it. And keep spreading the good word, you guys.
So we still have more questions. Next question, between ESR and CRP, which is better to assess anemia of chronic inflammation?
Well, that depends on the scenario, the clinical scenario. Normally, we in the perioperative area, we used more CRP. However, the rheumatologists, for instance, they rely more on the length of the erythrocyte sedimentation because it lasts longer on the time, so they can control the patient better. The main problem, at least in Spain, is that the length of erythrocyte sedimentation is no longer available in many hospitals. So we are relying mostly on CRP. But I think if any of them that is elevated is indicated of an inflammatory component, and then that help you to decide which therapy you choose to treat the anemia of the patient.
Can I just join in and add one thing? We looked in our anemia and cognition paper at RDU red cell distribution index or red cell distribution width, RDW, red cell distribution width, and that was profoundly related, profound 0.00000. I mean, way
No,
off,
sorry.
way off.
Bruce, I agree with you, but this was not the question. The question was the sedimentation rate against CRP.
Right.
Yeah.
Sedimentation rate versus the other one.
Yeah.
And
I absolutely agree with you that the erythrocyte width is a highly predictive factor, not only to the response of several treatment, but also is a risk factor for mortality in patients with heart failure, for instance. So
absolutely, and it's so easy to get. That was going to be my point. Is to do sed rate and to do other ferritin levels and such things require more and more distant workup. But the RDW might be a screening tool that again most physicians don't know about.
No, and also if you order reticulocyte, you should order hemoglobin content also, and you don't need the ferritin or the transferrin saturation.
Right.
Okay.
There's a question for Onyinye about, are there any cases where the use of erythropoietin alpha would be preferred over erythropoietin beta?
There are no cases actually. It's obvious that erythropoietin beta has some higher molecular characteristics than that of erythropoietin alpha, but their results are comparable. Both the efficacy is quite comparable, so it doesn't have any advantage over the alpha. So either one could be used depending on what is available where you are. And also when it is properly stored, it makes for more efficacy, because when you get the ones that are not properly stored, you'll be giving the injection and there'll be little or no response. But when it's properly stored and transported, another thing is during the transportation stage, some people forget that it has to also be transported cold chain. And when it is not done that way, then it gets denatured and the results you're getting may not be good.
Thank you so much for that. And we are so pleased with the level of engagement. In fact, we know there are many more questions in the chat box. Perhaps we can, some of the ones that they are addressed could answer them during the chat bar, or we could maybe address them tomorrow. But we do want to thank everybody for their participation, and we certainly feel that we got this first day off to a fantastic start. So I just was going to review the, give an overview of the session for tomorrow. I'm just going to share my screen.
Before you do, please, can you see the result of the one question that we asked about the continent? Can you see the poll results?
Yes.
Yeah.
This time we've got Europe, but we still have a lot of work to do there. So we may still request Professor Munoz to help us to bring more people from Europe. But thank you very much to the ones from Europe who are here. Please spread the message. Over to you, Sharon.
So I was going to share my screen. Let's see. Nathaniel, I think you have to unshare your screen. Were you still sharing or no?
No, I'm not sharing anything.
Okay. Can everyone see? So just in terms of tomorrow, again, tomorrow is World Bloodless Surgery Day. And so we're going to start off with a World Bloodless Surgery Day lecture, which is entitled Bloodless Cardiac Surgery. So this is going to be an excellent talk dealing with the ultimate art of surgery, not only regular cardiac surgery, but also to bloodless heart transplants. Moving along, we're gonna, that's coming from the University of Chicago, and then coming from the center at Inglewood, Dr. Koff is gonna talk about perioperative techniques to minimize blood loss. Following that, electrosurgical principles in the control of surgical blood loss. So again, looking at all these things to address minimal blood loss in the surgical arena. Again, I'm sure also to be followed by a robust Q&A session and then some bloodless medicine and surgery videos. So again, thanks everyone for your time. We know that we went a bit over today, but that goes to show that there's great interest in the great work that we're all doing. So thanks so much for your time. Have a great day.
Thank you. Bye-bye.
Bye-bye.